receptors in the blood vessels, the kidney and the brain and the heart help maintain homeostasis. If you guys remember, we talked a little bit about this baroreceptor and chemoreceptors, which are going to change the way that our heart reacts as far as like the rate or the strength of the contraction, as well as what happens in the vasculature. So the baroreceptors are set up in the carotid bodies. I mean, they're throughout most of the body anyways, but they're going to sense when we sit up too fast or stand up too fast and we actually lose a little pressure to the brain. You can kind of get that dizzy sensation once in a while if you do something like that a little too quickly. And the baroreceptor will note that the pressure is decreased, and the automatic response to that is to constrict the arterial side of the system. Chemoreceptors sense changes in the chemical composition of blood, and so that could be any number of things, right? That could be the carbon dioxide levels increasing, the O2 levels decreasing, and various other things that are telling the body to either vasodilate or vasoconstrict, and then actually have the heart increase its rate and contractility. So the cardiac cycle basically starts with a myocardial contraction, and then it ends at the beginning of the next contraction. So that's one full cycle. The contraction results in pressure changes within the heart chambers, and that's that lub-dub. So systole is ventricular contraction pumping into the systemic circulation, right? And so that is the peak pressure at the end of the contraction. And then diastole is when the heart's in its relaxed phase, at least on the ventricular side, and that's the lowest pressure, right? And so those two will give you a mean arterial pressure if you know the math. Preload is the amount of blood returned to the heart to be pumped out, right? And so that is generally a result of how much the systemic pressure has pushed blood into the atria. And then as the atria push blood into the ventricles, that is preload for that. Afterload is the actual vascular resistance in which the heart has to pump against, right? So if you're looking at, say, perhaps somebody who has high blood pressure, that person has an increased afterload because of the systemic pressure that the heart has to push against. Stroke volume is the amount of blood ejected per contraction. And then if you want to discuss that a little bit further, you can go into ejection fraction, which is just the actual amount of blood that was in the, we'll say the left ventricle, that has been ejected into the body after that contraction. And you would normally think, well, it should probably be about 100%, but that's actually not the case. It's wildly impossible to try to get all the blood out of the left ventricle with a contraction. And what most cardiac physicians are going to tell you is that a very normal ejection fraction is somewhere between 50 and 60%, maybe as high as 65. But anything more than that is improbable. And are you able to measure that in the field? Absolutely not. But it's good to know, especially if you're working with somebody who has significant cardiac history. Maybe they've had significant heart damage and they tell you that they have an ejection fraction of, say, 20, 30%, right? That person has lost a significant amount of the heart's ability to pump. And so you know that they're generally pretty fragile. Cardiac output is stroke volume times heart rate, and that's in a minute, right? And so that means if every time the left ventricle, say, pumps out 37, mLs per beat, and then they have a heart rate of 100, right? You know that you have 3,700 mLs per minute for the cardiac output. Now, if you think that most adults have somewhere between 5 and 6 liters of blood in their body, and that it's being cycled every minute, you can kind of do the math and figure out where you're at on that. Some of the factors that influence the heart rate, the stroke volume, or both will affect cardiac output and perfusion to the body's tissues. So again, if you have a bradycardic patient, somebody who's not actually beating appropriately, right, they're not able to create that perfusion, they need a rate increase. If they have insignificant ability to push against systemic vascular resistance, that's going to affect the stroke volume leaving the heart, right? And so again, all of these things are going to kind of compound into that situation where we're not getting perfusion or creating perfusion in all of the body's tissues. The presence of pulses is a good indicator of blood pressure, right? So I'm sure everybody remembers the 80, 70, 60, and that's a radial pulse roughly being a systolic pressure of 80 or better, and the 70 being a brachial, and then 60 systolic being the carotid. So if you guys kind of remember that, it's not always hard and fast the rule, it's just a general association. We know that if you can feel a pulse, that there's actually a heartbeat and some kind of blood pressure. Starling's law is, in a real easy way to put this, is the amount of preload or pre-stretch to a muscle is directly proportional to or helps result in the increased contraction, right? And so you can kind of play around like this and kind of just figure out where you're at. But if you take your arm and you kind of flex your arm and you just barely open your arm back up and then you kind of flex it back again to close it, the contraction is pretty weak. Now, if you take your arm and you completely extend it so that it's 180 degrees open or a straight line, and then you flex to bring your arm back up into a closed position, that contraction was actually significantly stronger to perform the same action. So that's very similar to how the heart's working, and it's just an easy way for you kind of to physically see the same representation of what the heart's doing. Blood is the substance that's pumped by the heart through the arteries, veins, and capillaries. It's consisting of the plasma and the formed elements, or the red blood cells that are suspended in the plasma. This is also white blood cells and the like. Plasma is watery fluid that makes up more than half of blood. Again, we're talking about the cells, including red blood cells, white blood cells, and platelets. Blood carries oxygen and nutrition to the tissues, and then waste products away from that tissue. Red blood cells carry oxygen to the tissues. They're disc-shaped. They're also called erythrocytes. They contain protein called hemoglobin. Hemoglobin carries the oxygen by binding to it. The erythropoiesis is the ongoing process in which red blood cells are made. So if you're thinking about this, and I think we talked about this in one of the previous lectures, red blood cells are red because of the iron content on it, and that's actually kind of a weird process in which the oxygen sitting on the iron inside the red blood cell actually oxidizes it and turns it that rusty color, which gives red blood that look, that dark kind of brick red look to it. White blood cells are called leukocytes. There's several types, and each of these leukocytes has its own function. Some of them are going to be very specific in how they operate inside the body and what they're trained to do. You can think of white blood cells as kind of like your mercenaries, right? They're sent out to kill other cells or foreign invaders like bacteria and virus if they're able to. And they all have their own functions within the body. It's basically set up to fight infection, and then in some cases they're going to be able to kill the bacterial and viral invaders. All right, so platelets and blood clotting. The platelets are the very small cells in the blood that actually form the clot, which is called coagulation. And it's actually a complex set of events. There are 12 clotting factors to blood, and if any one of those is missing, that person is very unlikely to form normal clots, which is the platelets and the clotting proteins in the plasma actually building a gelatinous mass in regards to the body trying to basically keep itself from leaking out of a disrupted vessel. The blood vessels, this is pretty elementary. You guys should know this just from your EMTB. Arteries carry blood away from the heart through the body and then branch into arterioles and then divide into capillaries. Oxygen and nutrition pass out of the capillaries into the cells. Diffusion is that process, right? Everything is looking for balance. So if there's an excess of oxygen inside the blood and the cells have a lack of oxygen, it's going to try to offload to create a balance, right? So not all of the oxygen is leaving the bloodstream. It has to have that need or that ability to actually create some kind of balance in that diffusion process. The capillaries enlarge to form venules, and this is after they've went past the cells that they're feeding. And then those also merge and form into veins. The veins bring blood back to the heart, and then the blood is sent to the lungs to be reoxygenated and then returned to the heart to start the process again. There are 3 layers of any of the blood vessels, and that's the tunica intima, which is the endothelium, and then you have the tunica media and the tunica adventitia, right? And so again, you guys really got to stay up on top of the fact that there's a lot of Latin involved in this. And so this is probably another test question for you, right? And so you should probably pay close attention to this and understand where those 3 layers are and which ones are labeled as such. So now we're looking at the blood vessels and circulation to the heart. And like I said previously, if you're looking at coronary arteries, they are right off of the aorta, right after it leaves the ventricle, right? The heart's going to feed itself before it feeds the rest of the body. The right coronary artery divides into 9 branches, and the left coronary artery divides into 2 branches, which then subdivide themselves. And if you're looking at the pictures, you should probably know basically where those structures are as far as right coronary artery and left coronary artery. I do not believe that any of your test questions are going to get into the actual vasculature in very much detail. Pulmonary circulation is the blood from the right side of the heart being sent to the lungs, then the blood coming back to the left side of the heart from the lungs. The systemic arterial circulation is blood being carried from the aorta to all parts of the body as it divides into the ascending aorta, the aortic arch, and then the descending aorta. So if you think about this, that's that large trunk coming off the top of the heart. It's arching and then it runs down, right? And again, when we look back at the previous lecture on anatomy, the aorta and the vena cava run along the spinal tract, and they're going to branch out into the arteries and the veins as they get down into the pelvis and then get into the femoral artery and the femoral vein. Now, while we're talking about the pathophysiology of the cardiac tissue, chest pain is usually related to cardiac cell ischemia, which means that we're kind of lacking that oxygen, that oxygenated blood to the heart muscle. The heart muscle fails to get that oxygen and nutrition. The tissue starts to starve. And again, the brain and the heart really do not fare well in an anaerobic environment. And so those tissue or cells will die if blood flow is not restored. Ischemic heart disease means that typically you have decreased blood flow to one or more portions of the heart muscle. And this is often undetected for years and years and years until we have that big event, that AMI, right, or acute myocardial infarction. As plaque and other things build up inside the coronary arteries, we actually decrease the blood flow through that particular vessel, and that's that ischemic heart disease, right? And so when somebody has what we call angina, which is that chest pain, that is the end result of somebody with ischemic heart disease. So if you induce them to have a myocardial demand, or the heart's demand for oxygen and nutrition, and it's unable to create that blood flow, they will develop that angina or that chest pain as a result of that. So just as we were talking about just a minute ago about that narrowing of an artery, you can see here in the picture atherosclerosis, which is the diminished blood flow of the myocardium caused by that narrowing, right? So if you're looking at the picture in the lower section, you can see that there's plaque and that narrowed artery. And as we do that, I mean, flow is all relative to the actual orifice size, right? You can only do so much with pressure, but if you don't have that cross-sectional diameter, you can only have so much flow through it. And as that's more and more restricted, it's harder and harder to provide the normal blood flow to that tissue. And then when we increase any kind of cardiac demand, it's going to cause a significant reduction in its ability to keep things fed and oxygenated. Now, thickening of the arterial walls is something that can cause that, and then you can have a loss of elasticity, and when we have that loss of elasticity, blood pressure rises, and then if there's any kind of plaque that is formed because there was a micro damage to the vessel, the plaque will form over that micro damage, trying to actually kind of keep the integrity of the arterial wall. If it was to become dislodged, it can actually tear, or this now becomes a thrombus, and then it travels and blocks off blood flow at a smaller portion, much like when we went through the stroke section. So now we're looking at that thromboembolism, right? That blood clot that floats through the vessel until it reaches that narrowed artery, just like we were just talking about. It stops and blocks blood flow. Anything down from that section is going to become hypoxic, and this is really what we're causing an AMI with. The AMI, the acute myocardial infarction, that's the Latin way for saying heart attack. The infarction means death of tissue, right? And that may also cause death of cells in other organs, because again, if we're losing a large chunk of the heart because it's dying tissue and we're unable to actually perfuse the rest of the body, other organs are going to end up in failure as well because of the inability to perfuse it. So as per this slide, there's some controllable risk factors. There is some science out that actually kind of negates what some of this is said, but you should probably know a lot of what's on here for some of the testing purposes. I'll dive a little into it, right? Everybody knows that cigarette smoking is bad for you, so I'm not going to beat that horse. High blood pressure is quite often actually mostly genetic. There are some lifestyle choices that can slow the rate or onset in which your blood pressure becomes higher, right? Obviously, a lot of people who are active and very physical will slow the rate in which their blood pressure rises above normal. But it's not a foolproof guarantee, right? We can't control blood pressure solely on the way that we eat or the way that we exercise. It's very much a genetic thing. Elevated cholesterol levels are in this particular section. Now, your dietary considerations have very little effect on elevated cholesterol levels. And truth be told, if you're really looking at this, cholesterol levels pre-AMI have very little to do with a cardiac event. Now, cholesterol is a precursor to many hormones, and it has significant roles inside the body. Elevated blood glucose levels can actually kind of contribute to your risk of an AMI, because as the body pushes more and more glucose into the blood will then become more and more viscous, which creates a condition where the heart is unable to actually pump against that increased afterload. Lack of exercise is there. Stress is very much a contributor to AMIs, in which you can say lack of exercise will kind of contribute to that, right? So the inability for the body to respond or have that kind of ability to work in a increased afterload or increased demand, right? Stress, we're talking about adrenaline and cortisol, are all factors that are going to create that situation where the cardiac tissue has been over-exercised over a long duration of time and has pretty terrible effects on the cellular capabilities. Major risk factors for AMI that cannot be controlled. As we get older, obviously, right, you could almost surmise that there's maybe a set number of beats that a heart is able to produce in its lifetime before it ultimately fails. No one actually knows what that number is, but I mean, it's just a general consensus that some people have genetics that will allow them to go a lot farther into age. Family history of coronary artery disease, Again, that kind of ties back to the high blood pressure and just artery disease in general. That is a heavily genetic component on whether or not somebody is going to have that ever increasing afterload, which is going to create a hypertrophy of the heart, which then ultimately causes some heart failure. And then obviously this says male sex, and that means the male gender, right? Men tend to suffer from coronary artery disease and cardiac issues as a complication of such, more so than women, although in 2020 it's looking like females are actually increasing to catch up with the rate of men, and we're still not really 100% sure on why that is.